And why don't they want to learn it? And why don't they want to learn it? Good Lord.
The remix. Don't they want to learn? You know, don't they want to learn?
I like it.
Can't push the button fast enough. Thank God. Okay. So determine why the patient is being uncooperative. That's your distractor. That's pretty darn close, right? It sounds kind of the same thing. The difference is, one, it's missing the word assessment, right? And two, being uncooperative is a fairly negative way to put anything. She's not being uncooperative. She's distracted. There's something wrong. She's not saying, no, I refuse to listen, okay? Also, when you say determine why the patient is being uncooperative, are you not making an assessment? The assessment being that she's uncooperative? So you've assumed already, not assessed what the problem is, right? Give information in writing and let the patient read it, just like the handouts. Does that do any good?
No.
No. Now, I have done that. I have said, look, you know, clearly this isn't the right time. I can't make it better. Well, let me give you this and read it, and we'll follow up next time I see you. That kind of thing. But I know it doesn't work. And then stop the teaching session and return at a later time, which is kind of the same thing. But again, you're not making an assessment yet. Okay, you haven't even started that process. Okay, so that's why assessment, that's why A is the right answer. And only 39% of you got it, but that's okay. See, the patient and the family are having a nursing diagnosis of impaired verbal communication secondary to language barrier. What action by the patient family would best indicate short-term goals for this diagnosis has been met? So, what part of the nursing process is that? Nope. Where is the assessment?
Evaluation.
Okay, it's an evaluation, right?
Yes.
So we've already made our assessment and our diagnosis because they have impaired verbal communication due to language barrier, right? So now we're looking for the short-term goals, which is what is our evaluation piece? What are our goals? Able to communicate long-term desires for the health of the patient? Does that sound right?
No.
Well, because it says short-term goals, you certainly wouldn't talk about long-term goals now, would you? Okay. Demonstrates comprehension by head nodding and saying yes.
Doesn't mean
Has anyone ever been in a foreign country? Anyone ever been in a place where you don't speak the language? You do a lot of... Move on, I have no idea what you're talking about. So clearly that is not effective communication, okay? States understanding of the condition and treatment via an interpreter. What do you think?
Yes.
I like that one, right? We use interpreters all the time in the medical field. Most hospitals have an interpreter service. You just call them, say, I need an interpreter who speaks Farsi. No problem. 30 seconds later, they got an interpreter who speaks Farsi right there on the phone. It's amazing stuff. I've never yet had a language that wasn't covered. Yep. Understands how nonverbal communication varies between the cultures. Does that have anything to do with short-term goals for this?
Well,
No.
We're not for
Go ahead.
I picked that one, and I'll tell you why I picked that one.
Uh-huh.
Because it's a short-term goal. To me, when I was reading the question, I saw C as the long-term goal. That you would, long-term, you would state the understanding, the patient would state the understanding of condition and treatment via an interpreter. But I thought to get to that point, they had to understand how nonverbal communication varies between cultures.
Okay,
Well,
well,
they need to know though.
let's ask yourself, how are you going to understand, how are you going to assess that they understand?
I guess with an interpreter.
Through an interpreter, right? So you can't do this until you have this.
True.
All right. A nurse is caring for a patient near the end of life. So a nurse is caring for a patient near the end of life whose wishes regarding the care are not known. The two sons disagree with the two daughters about future medical plans during a recent family conference, and now the sons and daughters are not talking to another. What action by the nurse would best help resolve this dilemma? Okay. So let's go back to what we already know. Assess. What do we know? We know we have a patient at the end of life, right? We know we have two sons and two daughters, and we know that they don't agree on the care. They've had a meeting, and they now are not talking to each other. So we know that's the information that we know. right? So our diagnosis might be something like impaired family interactions related to disagreement over end-of-life care, okay? So now we have to, the question is, what action by the nurse would best help resolve this dilemma, okay? So the question is, what resources are at your disposal? What could you possibly do without looking at the answers? What could you possibly do in this
You
situation?
need a mediator. You need a mediator.
A mediator works wonderful. Where do you get a mediator from?
Social worker.
Social worker, okay. So the question about social worker says, have social work coordinate another family meeting to discuss the issue. So they've already had a family meeting and it
But
already
maybe
failed.
that there was nobody, it could have just been like them.
Don't
is
read
what I
into it.
thought. Well, I'm saying, I just thought,
I
because
know.
it didn't say anybody else was there, it just said they had a family meeting. So it
Right.
was like the 2 sons, 2 daughters. And that's what I thought, well, let's get a third party there so we can see if we can talk it out before you
So-
go to the ethics board.
In nursing, when you talk about having a family meeting, you're not talking about sitting around a dinner table. You're saying, you have had this meeting with you, the doctor, and the family, all
Yeah, I
together
didn't
as a
get that.
group,
Yeah, I didn't get that.
okay? That's what a family meeting is, okay? You had your hand up.
I didn't choose B because it was pointless if they had already visited that and it didn't work.
Right, and that is why B is not good, because we've already tried and failed,
Right.
okay?
So why try again if you're gonna probably end up with the same result?
It might make things worse, exactly, right? So that's why B isn't necessarily the right idea. So what about meet with the sons and daughters separately to discuss their wishes? Why not?
Because
Well,
it'll
'cause you're
cause
hitting
turmoil
what gets
between them
different.
all finding out.
Right? If mom doesn't agree, let's go to dad. If dad doesn't agree, let's go to mom. We know how well that works, right?
I looked at that differently.
Yeah,
See if
go ahead.
I got that wrong. I don't know, because I was just thinking, if we try talking to them together, it's not working, I figure maybe talking to them separately to hear what they want, you know, and then we could address it later.
Oh, and you can
But
be
I read too deep into it. trying to-
That's not a horrible answer.
it's
right?
not the best.
It's one of those frustrating things about nursing, it's not the best answer, right? Request that the physician tell the family about what's in the patient's best interest?
No.
No, 17% said yes. Why is that
Well,
never a
why?
good
What's their
idea?
thought? I don't know.
The
Did anybody-
physician always say.
Because it's not his choice.
Because what
This is very paternalistic, right? You're not,
That's all
they're
right.
not the boss. Who are they, what do they know? All you're asking is what's the physician's opinion, right? And the physician's gonna, and you know that's, by the way, in nursing school, ask the physician is almost never the right answer, okay? It's very rare, ask the doctor is the right answer, it's very rare. It has to be like, hey, this patient's pumping blood out of her femoral artery. You might wanna call a doctor on that one. But only after you've applied direct pressure, right? Ask the doctor is very, very rarely ever the right answer in nursing school. Yep. And so that only leaves us with this one about the ethics committee. Now, I understand the ethics committee may not be something you have a lot of experience with. Ethics committees in hospitals are ad hoc committees made up of 4 or 5, usually an odd number, of senior folks in the hospital, like the chief of nursing, the chief of medicine, the chaplain, the hospital's lawyer, something like that, okay? And they will meet at 3 o'clock in the morning to discuss a problem, you know? And so they are the mediator. They are the one who says, okay, so what is ethically appropriate for the hospital?
I thought
What
they were
can
the
we do?
deciding factor,
What's that?
though. I thought they like make
They can't
the
decide.
final decision, like
Well-
the ethics committee.
Well, they don't get to sign anyone's consent forms, right? But what they can do is they can say, this is what the hospital is willing to do for this person. Ethically, this is what we're allowed to do. Ethically, we think it's okay to force this woman to have a C-section to save the life of her baby. We think that's appropriate, that's what we're gonna offer. Okay, so that's what ethics committees do. And so if it's end of life, they can say, look, the treatments have been exhausted, there's really nothing else we can do for her, and ethically, it would harm the patient to continue on. The hospital will no longer offer services. Okay, and then the family can decide, oh gosh, it's out of our hands, fine, we'll let her die, or no, we'll go to another facility. And that happens too. But that's the value of the ethics decision.
Don't ethics committees also kind of like make like recommendations?
They do.
Like, cause I know like when you wanna get put on like a transplant list,
Mhm.
you have to go through an ethics committee.
Mhm.
And they recommend if the patient should or shouldn't be put on.
Oh,
Can you
The-
come down?
I'll uncover them.
Can you come down a little?
Sure. Okay. All right. So, a young woman has 3 urinary tract infections in the last year. What teaching should the nurse plan for this patient? So, what do we know from assessment? Young woman, UTI. Okay, 3 UTIs in the last year. Right? What's our diagnosis? Could be knowledge deficit, right? All right, because we're going to talk about teaching, so we're going to assume it's a knowledge deficit related to perineal care. Okay, so then what's our intervention? Okay, don't know how to write. There you go. So does avoid intercourse during your period have anything to do with UTIs? No. Does take prophylactic antibiotics daily, would that be an appropriate intervention?
Because wouldn't that
Not-
exacerbate at the same time the UTI? Because like if you take it daily, then it's getting rid of all your normal flora in your body.
Exactly. It's kind of overkill, right? Okay,
Are antibiotics prophylactic though?
they can be.
That's
Void every 4 hours while awake.
Who got time for that?
It's not a horrible plan. That's not a horrible plan, and that might be part of my plan down the road, right?
Right.
But what's the easy thing to do? You wipe from front to back, don't you?
Yeah. Just putting the bacteria.
Yeah. I always tell people everything goes from front to back, nothing goes from back to front. I don't care how fun it is, nothing goes from back to front. Okay, ever. Okay, once it's touched your bum, it can't be anywhere near your urethra. It's a bad idea. But you guys know what the number one bacteria found in urinary tract infections is? E. coli. Number one, because the waist dump is too close to the recreation zone. Plain and simple. It's all in the same area, and your underwear will carry E. coli forward to the urethra. So it's not a matter of going from anal sex to vaginal sex, it's just that the two are too close together. We don't need to make it worse by going from back to front. So the answer is wipe from front to back, okay? Now that that's said and done, in pregnancy, we start with wipe from front to back, and then we say, oh, you've had 3 urinary tract infections in this pregnancy? Take macrobid every night for the rest of your pregnancy. Because wiping from front to back didn't work, we now have to go to the next step. And urinary tract infections in pregnancy can kill you. So, or kidney infections can kill you. So it's a little different, but where this is just plain GYN care. So the nurse is planning breast education for women. What information does the nurse plan to provide about breast cancer screening recommendations? So this is a basic knowledge question. You just had to know it. Okay? And the answer is? Annual screenings after age 40, exactly. Age 40 is when we begin breast cancer screening. And how about the next one about the thyroid? 50.
50, yeah.
50 is the answer. Okay? At what age should the nurse prepare patients to begin thyroid function screening? The age is 50. Now I understand your slides had a greater than 50, okay? Which means from the day she turns 50 on, she should have thyroid screening. I guess on the day of her birthday, she can avoid it. But the next day she can. But definitely you don't want to go with 60 because that's too far down the road. You don't want to go 10 years without beginning thyroid function screening. It's annually after 50. Okay? The nurse knows what part of the uterine cycle that occurs during the period of time between ovulation and the onset of menses is known as which part? So a lot of people got confused by this. A lot of people, okay? So it's important to understand what the question said. In the uterine cycle, what is the part between ovulation and onset of menses? So from day 15 to day 27 is what cycle? Secretory. Exactly. A lot of people said ischemic, but ischemic is day 27 and 28. That's when blood flow is cut off to the area and it sheds and you start to lose your endometrium, right? So had it said, what is day 27 and 28 of the menstrual cycle, ischemic would have been a good idea. But understanding that the secretory phase, and a lot of people said proliferative too. Proliferative is the first part. when things are just beginning to grow. But a secretory is the part where the ovaries are releasing all their estrogen and progesterone. You got that big hump of messy looking stuff in the diagram. That's the secretory phase. And it's called that because that's when the ovaries are secreting their stuff. Okay? A pregnant woman calls the OB nurse to complain about sharp abdominal pain with coughing, sneezing. So what is the assessment? What do we know?
She's having abdominal pain with coughing.
That's an assumption. Well, no, you're right. She's having abdominal pain with coughing. I'm sorry. I thought you said abdominal. Okay, so you're right. She's having sharp abdominal pain with coughing. What else do you know?
She's
pregnant.
She's pregnant. Okay, good. That's a very big piece. Because if she weren't pregnant, that would be a totally different diagnosis, would it not?
Right.
So, we know we've got a pregnant woman who's having sharp abdominal pain while coughing or sneezing. Do we know anything else about her? Anything we'd like to know about her?
How far along is she?
How far along is she? That sure would be useful, right? But we can't get that information. So, our assessment is pregnant woman, sharp abdominal pain, only while coughing and sneezing. Okay? So, let's go through our diagnosis, our differential diagnoses. What could it be?
round ligament pain.
It could be round ligament pain. What else could it be?
Cold.
Okay, could be a cold, sure. What else could it be?
Could, I mean, this might sound like a gas bubble. Like
Could be a gas bubble, although those are usually not associated with coughing or sneezing, right? Could it be contractions?
She probably thinks she's having like Braxton Hicks.
A lot of them think they're having Braxton Hicks or they're having contractions. But the fact that it's only while coughing or sneezing and not with anything else tells you that it's probably round ligament pain, okay? So we've assumed a diagnosis based on the assessment that we have and explained that the pain is from stretching of ligaments. Not a bad choice, right? Have the woman count her contractions each hour while awake. Would be wonderful if she was having sharp abdominal pains that were rhythmic or sharp abdominal pains several times an hour. But this is sharp abdominal pains only when coughing and sneezing. So it'd be like saying, count your sneezes, right? So it's probably, we've ruled out it's probably not contractions. Place the woman on bed rest until her next clinic visit. What's wrong with that?
It's not gonna.
It seems like an overkill, like if you don't know.
It's kind of
like too
overkill.
much.
Good. Okay, what else?
Something could really be wrong with her, and you're just gonna put her on bed rest.
You
Well,
need to see her first.
that would be assuming that there was something really wrong with her. Okay? But how about this? Who writes the order for activity? Doctors. That's a medical order. Okay? If this were going to be a nursing order, it would say recommend the patient take it easy, or recommend the patient rest until her next appointment, that kind of thing. Okay? That's what a nursing care plan would look like. It wouldn't say strict bed rest. Nurses don't do that. It's not a nursing order. And then tell the woman to come into the clinic today. It's not a bad idea, right? But it's not the best idea. Okay? So our two that are obviously wrong are B and C. Tell the woman to come into the clinic today. Never a horrible plan, but it's not the best plan, which is to explain round ligaments, that this is a nursing function, this is anticipatory guidance, that what this woman has is knowledge deficit related to round ligament pain, right? So what she needs is an understanding of what she's experiencing.
Could you preface that with that
If it doesn't get any better,
or if it's persistent, then come into the clinic?
sure could.
That's one of those, somewhere in this.
There is. There's one about if it continues or whatever, come in, and that's the right answer for that one. The perinatal nurse reads in a chart that a woman has a lesion on her perineum. Where would the nurse assess this lesion? What this is asking is where is the perineum, right? So where is the perineum?
In between, in the holes.
The taint. That's right.
I was thinking.
Taint the vagina, taint the anus. It's something in between, right?
In between the holes.
So that is the skin-covered region between the vagina and the anus.
Those first couple, I was doing pretty good. Went downhill from there. Downhill from there.
Perinatal nurse knows that the lowest portion of the true pelvis is which of the following anatomical landmarks? That's a tough one. So we talked about the true pelvis versus the false pelvis, right? So the lowest portion of the true pelvis is which anatomical landmark? So is it the pelvic outlet? Do you guys know what the pelvic outlet is?
And there's the top.
There it is.
Ding, ding, ding! We figured out why we got that one wrong. It is the pelvic outlet.
Wow.
Okay.
I don't even know why I put what I put on here.
Which, you know, if you didn't know anything at all, pelvic outlet sounds like the end of the birth canal, right? The linea terminalis, if I remember correctly, the linea terminalis is from symphysis pubis to the sacrum.
But
Isn't
isn't
one
that
of
what
the
divides?
What's that?
That's what divides the true pelvis and the false
Yeah,
pelvis.
that's what I remember
Could be.
that being.
It
Yeah,
could-
that's what it says.
That's what it says in
Okay.
the book.
I'll take your I'll take your word for it.
Don't tell me. I read my book.
I moved on from this test, so. The sacral promontory, that's the hump at the back of the sacrum.
What was the form of each and every question?
If I can I probably don't have time for it. You want me to just hit the ones that we failed miserably on?
Well, can we do something like if you've got a deep burning desire, go to your office?
Sure.
I know we've got a big lab tomorrow and I wanna get through lecture too. I wanna
Okay.
ace my next exam too.
I figured I'd give you guys until 2 o'clock
I do.
for this
I
test.
missed it.
So
Okay, I was
we'll
just
go
curious.
until we run out, until we get to until break time.
Okay.
And then I'll start lecturing for the rest of the course at 2, okay?
Can we do it like, to where you're going through, the right answer, and then if somebody has a question about like why that was chosen?
Sure, you just want to know the answers?
And then it, like, if we need to
Okay.
understand, and the ones that you said like we did really bad on, you know.
Okay,
just
that's fine.
explain those.
13 is a repeat of 9,
Yes.
so we'll just skip right over that one,
Wait. I'm good.
okay? So I liked 16, it's a good nursing diagnosis problem, or nursing assessment problem. Pregnant woman calls the OB clinic nurse to complain of sharp abdominal pain when, what is that, the same one we already answered? Never mind. Ah, 17 got a lot of people. Nurse explains to the student that the development of the lining of the uterus is mediated by which hormone, okay? Now this is a basic knowledge question. And what do you think the answer is? Progesterone, okay?
That's the word.
Now, the reason I intended to throw this out, but I wanted to see how you would do with it, is because you have to know that progesterone is an important hormone for maintaining the lineness, the uterus. Now, I understand, in lecture I said, estrogen does all the work, progesterone slows everything down, okay? This is the only time, pretty much, you're gonna find progesterone not slowing something down. Okay. Now the reality is, it's opening blood vessels, it's allowing proliferation of blood through the area, and it's building that area kind of through a roundabout way. But what's important about progesterone is that progesterone in early pregnancy supports the first trimester baby. That if a woman has a progesterone deficiency, she's going to have multiple miscarriages. One of the treatments for multiple miscarriages is progesterone's daily suppositories. And then in the second and third trimester, it's weekly injections of progesterone to prevent preterm labor. So you need to know that progesterone, especially a nice high level of progesterone, is critically important for supporting a pregnancy at all times. And that's why I decided to leave it in there, yes.
But isn't it because progesterone slows everything else down, isn't it allowing the prostaglandins to come out to thicken that uterine lining?
Sure. Yeah. But my point is that it makes it sound like the progesterone builds something, and I had said progesterone doesn't build, the progesterone relaxes. It's just a secondary effect of progesterone. But I left it in there, even though that's a little bit tricky, because you need to know progesterone is that important to maintaining pregnancy, okay? Because you're going to get confused, doctor's going to order progesterone, you're going to ask why, and the answer is because it supports early pregnancy, okay? Let's see here. Oh, positive HCG. Means she's pregnant,
Yes.
okay?
Oh, this is my rough day.
What's that?
Just talking myself out of
Okay.
a rough time, 1924.
Okay.
Can you write down just a tad?
I'm looking at it like blank, so I must have just put stuff on the bench.
You guys did pretty well in 19. Did really well on 18, not one person missed that one.
Well, that's good.
So for 23, what was the actual answer that you were looking for? Okay.
A nurse has been taught, now this is where this is important to read your question. A nurse has been taught, or the nurse has taught a woman about the physical signs of ovulation, or that accompany ovulation, okay? Which statement by the patient indicates the teaching has been effective? So it's important to understand you're asking for physical signs and you're asking for which of these four statements is true. Okay? Now I accepted A or B, but neither one of them are really good answers. Okay, and so that's why I kept it. So why is C and D not a good answer?
Thought it's
Why
them,
C
your
or D
kids
are?
getting ready.
'Cause they're not
ready
right.
for, like,
Yeah, they're not.
Right?
yeah.
Because they're not right. They're the wrong information. Okay? The thin, watery cervical mucus means that you are fertile. Okay? Not that you're no longer fertile. And sticky cervical mucus helps the sperm in place of the egg, it helps hold the sperm on the egg. The cervical mucus has nothing to do with the egg. Okay? So those two are automatically thrown away. They are your obviously wrongs. Okay? I can still conceive for 48 hours after ovulation was technically the right answer, but is that a physical sign? It's not. So I wouldn't have chosen that one either. Okay? And then B, my temperature will go up after ovulation. Will go down after ovulation. Remember, it spikes and then it goes down. So yeah, kinda, but not really. So that's why I gave A or B. I couldn't give credit for C or D because they were so obviously wrong.
Well, the reason why I picked these is because you said A is not a physical sign.
Exactly. A is not a physical sign, exactly. So that's why I gave A or B for that one, okay?
What was 20?
20, a nurse reads in a female patient's chart that she is Tanner stage 5. What does that mean? Means that she's mature.
Stages of
Yep. And so there's in pediatric development, there's Tanner stage 1 through 5, and Tanner stage 5 means she has hair on her vagina, she has fully developed breasts, and she has hair in her armpits, and she's fertile, or she's probably fertile.
I thought from lecture, I thought you were saying that she's not technically a Tanner stage 5 until she has kids.
Mhm.
Yeah. So,
Doesn't that mean she's mature?
yeah. But then I guess on the test, I was like, is it 5 or is it 6? So it's creating a whole different stage in my head. So.
Oh. Yeah, that's kind of like the different stage is kind of 4.5 before you before you breastfeed a child. You're not quite there yet. But when you are in Tanner stage 5, you're mature, period. That's as far as it gets.
I'm not sure.
Wait, I didn't
No,
see 24.
24. Can you,
Yeah, I'm sure.
Oh.
why?
Okay, woman complains of irregular menstrual periods and wonders why she wonders if she is perimenopausal or menopausal. Okay, so your assessment, her lab work shows high levels of follicle-stimulating hormones and low levels of estradiol. What is the best response by the nurse? So your assessment is woman, irregular menstrual cycles, high FSH, low estradiol. Okay, that's what we know about her. So now, what is the diagnosis? Okay, so her diagnosis would be knowledge deficit due to perimenopausal symptoms, or knowledge deficit related to lab values associated with irregular menstrual cycles, whatever you want to call it, right? So the intervention would be that we need to teach her something, but we need to teach her the right question, the right answer, right? So, A, no, in menopause the FSH is low and the estradiol is high. No, these two lab findings are not related to the climacteric phase, which is menopause. So these lab findings usually indicate menopause or perimenopause. And yes, you are definitely in menopause right now. Okay, so let's break down each one. First thing you have to know, in a test, if two answers are exactly the opposite, one of them is right. Okay?
Good one.
Almost always, one of them is right, and the other two are distractors. Okay? So, which two are opposite each other? What's that?
A and C.
A and C. Okay? Well, and not exactly.
B and D.
So, so let's start with this one. So, well, let's explain. If you are perimenopausal, what is happening in your ovaries and what is your anterior pituitary gland doing and what is your ovaries doing? So first of all, what is menopause?
2 years without period.
2 years without a period. So if she's having irregular periods, you know she's not in menopause, right?
Right.
Because she's still having bleeding, okay? So we can throw D off the list right away. Now, what is it that causes the cessation of menses?
Oh, you mean like cramping?
No?
Is that what you mean?
What is it that makes menopause happen? What is
Oh,
it?
menopause.
Physically, what is it?
Like
You've run out. What is failed? You have an organ failure. What's the organ failure? Ovaries. Estrogen's a hormone. Ovary, you have ovarian failure. That's menopause, right?
That sounds so sad.
It does, doesn't it?
I'm having failure rates.
So if you have ovarian failure, hormonally, how do the ovaries work? So there's a hormone that stimulates the ovaries to work. What's it called?
FSH.
Follicle-Stimulating Hormone, right? And it's on a negative feedback loop, right? So what that means is FSH surges until estrogen is produced. Estrogen is produced, tells the hypothalamus, the anterior pituitary gland, to stop producing FSH, right? Remember that part?
Yep.
So, if you are in menopause, is your anterior pituitary gland failed? No, it's working perfect. So what's it producing? FSH like crazy. Saying, ovary, get to work, what's wrong with you? And the ovary's like, sorry, I give up, I can't even send all the FSH you want, I'm not gonna work, right? And if the ovary doesn't work, what do you not get? Estrogen.
Oh.
You don't get estrogen, and without estrogen you don't get a period, right? So what happens is you have this enormously high level of FSH and no estrogen. Okay? So that's why these lab findings usually indicate menopause or perimenopause is the answer. You
Why
wouldn't
does
get
it
the other
menopause?
one, right?
Because
What's that?
why would it indicate menopause?
Well, it's one of the two. Because you're still in menopause, you're still going to have high FSH and no estrogen.
Oh, okay.
Whether you're perimenopausal or menopausal, it's going to be the same finding. Okay? Because the anterior pituitary gland is still going to work and the ovaries are still not going to work. Right? So that response is going to be the same. So really this was a question about, do you understand the negative feedback loop associated with hormonal response? By the way, it's important to understand this. This is exactly how thyroid disorders work too. Okay? Thyrotropin stimulates the thyroid stimulating hormone, but no T3 and T4 is produced because the thyroid won't work. So you get this high TSH and low T3, T4. Okay, that's a standard negative feedback loop. How about no. You guys remember the video with Kevin Bacon hiding in the basement, and his wife was yelling, "Jefferson Edward Briggs!" Remember that one?
Yeah.
And what he said was, after all that testing, I couldn't believe my choice in underwear was the source of my problems. So I had to go to boxers instead of briefs.
I just thought that was something that
I
they
thought you were
say,
just
like
showing
after
us.
the fact though. No, because I was like, you hear it a lot when they're like, okay, you want to change your underwear because you were thinking about having, getting pregnant
Yeah.
or that kind of thing. I just thought it was like an after.
And in your book, page 224,
Yeah.
there's a nice little paragraph about male infertility, and it says, active contact sports, smoking, and tight restrictive clothing are the three things that cause male infertility, most male infertility. That's not being active and being healthy, having enough exercise. That's not drinking, and that has nothing to do with circumcision. Okay? Smoking, football players, or like MMA fighters, and brief wearers struggle with infertility. And so this is an application of knowledge question. You need to know what causes male infertility, and then be able to troubleshoot what was wrong with that problem, with that patient. Right? You guys did pretty well on 27. 28, 29, 30. I threw out 29, I believe it was, or I
I
gave,
did good on that.
yeah, on 29 and 30, I said any answer is okay, all right? Those are the right answers, by the way. If you have a platypoid pelvis, you're gonna have a baby coming down in transverse presentation because your platypoid pelvis is a flat plate, and so he can't get through facing front to back. He can only get through facing side to side, okay, in the transverse. And then the other one is, it was just worded funny. Oval shaped at the inlet, but in the anterior posterior plane. So the inlet of all pelvises are oval shaped, okay? But this oval shape, instead of being this way, is this way. And so that's front to back is the oval. And so the baby will come in posterior because it's the anthropoid. Okay, because it's bigger in the back. Because baby got back when you got an anthropoid pelvis. Okay? Now let's look at number 17 because it was a good nursing diagnosis. I mean, a good nursing process equation.
33.
I'm sorry, 33. Reproductive health nurse counsels a 17-year-old woman who is interested in initiating contraception. So what do you know? What's your assessment? She's 17 and she wants to start contraception. Okay? So what that tells you right away is what do you know about 17-year-olds who want to start contraception? Are they looking at getting pregnant?
No.
Are they looking at getting pregnant in the next year or two?
No.
These are women who want to become sexually active, but they don't want to get knocked up for a while, right?
Right.
So we're thinking long-term effective contraception is the kind of contraception she wants, okay? That's where I would go with a 17-year-old who is thinking about initiating contraception. So which of the following short-term positive outcomes from the visit? So our nursing diagnosis would be something along the lines of knowledge deficit related to contraceptive options or a knowledge deficit related to contraceptive practices, something like that, okay? And so we're looking for short-term positive outcomes, able to describe how to obtain and use the contraceptive chosen. That sounds short-term to you?
Yeah.
Yeah, that's like 10 minutes from now, right? That she knows how to go to the pharmacy and get her medication, or she knows how to go to the nurse who's giving shots today and take her depot, or whatever she's going to do. Or she knows how to make an appointment for an IUD, right? Continued use and pregnancy prevention for 6 months, that's long-term, okay? If you can continue to use the same medication for 6 months, you're probably gonna stay on for a long time, okay? That first 3 to 6 months is where we fail an awful lot. Lack of side effects and complaints about the method after 3 months, does that have anything to do with knowledge deficit? No, nothing at all, right? So that doesn't work. And voice satisfaction with the method over 6 months, again, not really a knowledge deficit problem, but also it's 6 months from now, not anytime soon. And that's why, I'm sorry, that is long-term. I'm sorry, did I say short-term? The voice method, voice satisfaction with this method over 6 months, that's not a short-term goal, right? That's a long-term goal.
So why couldn't it be? Because the knowledge deficit indication that you made, or you mentioned, or whatever, is not necessarily mentioned in that question. So why would we first assume that she needs to have the knowledge?
It's one of the frustrating parts about nursing school. All 4 of those are wonderful answers, right? But where the best answer is the one that has the shortest amount of time.
I looked at
Okay.
it as it specifically said outcome of the visit, that specific visit. So when she leaves that clinic, B, C, and D
Yeah.
can't happen
Yeah,
at all.
you're right.
There you go.
Yeah.
That's a
So
good
A
answer.
is the only one that can happen out of that visit.
And that makes sense, because I wasn't looking like, I was just thinking about if we kept talking about, they need to stay on for at least 3 months so they know if it's okay or not or whatever. So I was thinking along the lines of that, yeah. I could see.
And you're not alone to choose C. 34,
33.
33.
33. 3 people chose that answer.
Hey.
Me.
Yeah.
Another person.
So,
I mean, we're pretty alone.
I'm trying to help.
Throw it out.
Okay. So 34, a lot of people missed number 34. I thought it was interesting. 4 people chose A, 4 people chose B, 4 people chose C, and 11 people chose D, which was, of course, the right answer, okay? So, nurse works with many people who self-identify as lesbian or bisexual. What action by the nurse would best address this population's needs, okay? Why would anyone use aggressive screening for sexually transmitted infections because someone is a lesbian? Lesbian or bisexual? Are they at increased risk or decreased risk of sexually transmitted infection?
Probably decreased.
Yeah, probably decreased.
It depends on who you ask, but it's either decreased or the same, okay? They're not at higher risk. And understand that most sexually transmitted infections come from vaginal to penile intercourse. And so if they're not slipping and falling on a penis once in a while, then they're probably not getting semen, right? I'm sorry, this is one of my favorite jokes. Okay. But no, they're not being exposed to semen, so they're not being exposed to the bodily fluid that causes sexually transmitted diseases, right?
Right.
So they have a lower risk. Now they do get sexually transmitted infections because they share toys without washing them, but that, you guys like,
No, I'm saying like hygiene, hello.
hygiene, hello. How many of you wash your husband's penis before you use it? Do you know where that thing has been?
Right?
Yes, I
do. That's not foreplay?
So, assisting with procedures related to conception. Why not talk about conception?
Maybe they don't want to be.
Okay, how about, what does the question actually say? What does the answer actually say? Assisting with procedures relating to conception. So this is helping her with a GIF or a ZIF or an ultrasonography, or this is an infertility question, right? Nowhere in our assessment did it suggest that she might want to get pregnant.
Right.
So why would we care about her conception? Now, contraception might also almost work, but even that is not a very high priority for a lesbian, right? I have had a lesbian who got pregnant twice, and I had to tell her, okay, so your choice of contraception is lesbian, but it's obviously not working for you. Because you keep, finding a penis to use and getting pregnant. So let's choose something a little bit better. Right, she found it. Every time she and her girlfriend would get into an argument, she would go to her old boyfriend and talk and end up having sex. And so he had fathered 2 children with her. Apparently, she only argues when she's fertile. So C, providing information on increased cancer risks. What do you think? Are lesbians at increased cancer risk? There's some information that they might be, but definitely not cervical cancer risk. Okay, their cervical cancer risk is lower, but their breast and ovarian cancer risk is a little higher. But that's really kind of downstream thinking when you have an obvious other answer.
I know why.
Okay, why?
Pregnancy.
Right, pregnancy. Pregnancy and breastfeeding prevents breast cancer, and
That should be extra credit. I got that.
penile intercourse causes cervical cancer.
Yes.
So, yep.
Either way.
Yep. So it brings us to the elephant in the room, which is using questions that do not assume sexual orientation. Because what did your book say about the healthcare needs of lesbian and bisexual women?
It's the same about that.
It said something about that. It said that they don't seek care until they're really sick because they don't want to be judged, they don't want to be embarrassed, they don't want to be insulted for being lesbian. And so they don't seek care. They don't go to their routine well-woman exams. They're not the kind of women who are having sex with men who need contraception, whose doctor won't give them a birth control pill until they've done a pelvic exam, right? So they're not, and when do women enter the healthcare arena? When they get pregnant. Are lesbians likely to get pregnant? Not very. So they're not getting care because they're avoiding care. And that's the thrust of that main question. That's the thrust of the question. What you need to take out of it is that you need to be non-judgmental. What's that?
You said 29 and 30, you selected, if you accepted any answer?
Yeah.
Okay, just making sure.
So let's see here. Anything on here? Let's see. .36, I took A or B. Okay, that makes everybody right on that one. Okay. 38. Only 3 of you got this question right, but I kept it because that is an incredibly easy question. So let's find out why it's an incredibly easy question. Okay. So this patient has been taught about the vaginal contraceptive ring. Which statement by the patient indicates further teaching is needed? So what is that question really asking you?
What's the
Which of these 4 are not correct, right?
Right.
And so this is basic knowledge about the vaginal contraceptive ring, okay? So, if it comes out at all, I need backup contraception for a week. What's wrong with that?
Well,
No,
you just stick the
it
thing back
depends
in
on how
there.
long, if it just comes out.
no, because
You should wash it off first, but yeah. Go ahead.
the maneuver ring, because of the way it's designed, it continually
Right,
expels hormones, so if it comes out for 2 seconds, you pop it back in.
Exactly.
Every time you take it out for a long amount of time, when you start your period.
right. And according to your book, what is the long amount of time? How long, if it falls out, you need backup contraception. If you leave it out for how long?
2 or 3 days,
3 hours.
3 hours.
3 hours.
different?
So 3 hours. So that's half right. If it falls out for more than 3 hours, then yeah, you need some backup contraception. But if it falls out, you put it right back in. Okay, so if it falls out at all, that's not the truth. So there is the right answer. The other one, the exact position of the ring is not vital for function. 15 of you chose that answer. That was a good distractor. It tells me my distractor was in place. But you're thinking cervical cap. You're thinking something that has to be up around the cervix, blocking the entry to the cervix. Remember, the vaginal contraceptive ring is not a barrier device of any kind. It doesn't have to be anywhere in the vagina. It just has to be in the vagina. Okay? Nowhere specific because it's releasing hormones into the mucous membrane. It would work just as well if you chewed on it. Stick it in your cheek. Because it will get the hormone into the mucous membrane. Okay?
Especially when.
Yeah, that's not pleasant. I would hope that you would take it fresh out of the package before you chew on it. Using tampons is not allowed or is allowed with vaginal contraceptive ring. No, you should not use tampons. Putting things in there, you have a high chance of pulling it out and losing it. Okay, so we say no tampons. And vaginal contraceptive rings are 96% effective. I'm sorry.
Wait,
I made that wrong.
So,
B, C, and D are all exact, what the hell did I just do? I hate when I confuse myself.
Me too.
We do it all the time.
Yeah.
Tampons.
So we know the exact position of the ring is not yet vital for function, that's true. Using tampons is allowed, yes, it's allowed. And vaginal contraceptive rings are
Why? You
96%
said it is
effective.
allowed?
Yeah.
It is, I'm
So
sorry,
you
it is
can use
allowed,
tampons.
yeah.
So why is it allowed? Because I thought it's only supposed to be like you take the ring out so you can have a period.
Yeah.
So why would you use a tampon with the ring in?
No, that's the point, is that you're not gonna have the ring in when you're having a period. So of course you can use a tampon,
It's not saying it's.
because it's
just
out
saying
already.
when
You can
it's
put
out.
anything you want in there
I don't like that.
with the ring out.
I didn't choose that one, but that was where my back and forth.
But the only one that is not true is A. If it comes out at all, I need backup contraception.
If you're putting a tampon in, you're putting a ring on it.
Yeah. If you like it, then you should put a ring in.
Oh, yeah.
Okay.
Oh, my lord.
39.
Oh, man.
9 of you got this one right.
Professor Johnston?
Yes.
Can you do that dance again?
No. It's on YouTube forever. You can have it. So 39. The nurse is teaching a group of women about emergency contraception. Which of the following, I'm sorry, about hormonal emergency contraception. Which of the following is not a benefit of this type of contraception? Okay? So, the answer was D. All right? Available in some forms over the counter. Is that a benefit? That sure is. Can be taken for 120 hours after intercourse. A lot of you chose that one because you thought it was false. It is true.
It's true.
It is 120 hours. Now, it works best in the first 24 hours. It works okay after 48 hours. It kind of works after 72 hours. But after 120 hours, you're wasting your time. Okay, it's too late. Okay? Because what does emergency contraception do?
And make sure you're not pregnant.
Nope. It
Prevents-
doesn't cause an abortion. What does it do?
It builds up the
Prevents.
lining so that it
Well,
traps, or
yeah,
it
true.
just, it secretes the whatever to
It just
build
doesn't
up.
allow
It traps the sperm.
that meeting.
It can
Meeting
shut
of
the
the
sperm.
minds. It
It also
doesn't allow-
delays ovulation.
Oh.
Gotcha.
So if you're 4 days late, if you had sex 4 days ago, and you were gonna ovulate, it happened already, okay? So you know, if you were gonna get pregnant, if you waited 4 days to treat it, it's probably too late. You're already 4 days pregnant.
But doesn't it secrete additional,
Cervical mucus.
right?
Yes.
Trap them in there in case the egg has already ovulated in
Right,
there.
but the semen is long gone after 4 days, right?
Oh, you
So,
know,
yeah.
4 days for sure.
Yeah. So 120 hours is too long. It's not very effective, and it's not effective at all after 120 hours. Okay? Okay, 41. A lot of people miss this one. And you can see 6 chose A, 6 chose B, 2 chose D, and 9 chose, 2 chose C, and 9 chose D. Okay, the answer was A. So, an adolescent is in the family practice clinic to obtain birth control. She began menstruating 4 days ago, and she wants Depo-Provera because of the convenience of the method. What action by the nurse is best? The answer is give her the shot. Why give her the shot?
Because she had her period, so it verifies that she's not pregnant.
Exactly, she's on her 4th day of her menstrual cycle. Is it possible that she's pregnant? No, she's 10 days away from ovulating, right? So there's no possible chance she's pregnant. She's on her menstrual cycle, okay? So we don't need a urine HCG if someone's on their menstrual cycle. We know they're not pregnant. Now you could ask the question, well, what if she has irregular menses? What if? Don't what if yourself to death. You have to assume that the test knows that if they're on their menstrual cycle, they're on their menstrual cycle. Okay? The test said she's on her menstrual cycle. It doesn't say, we think she's bleeding. It says she's bleeding and has been for 4 days, right?
She may have been menstruating.
Right, it doesn't say any of that, right? She began menstruating 4 days ago. Even if she began menstruating 4 days ago, she bled for 3 days and she stopped, she's still on day 4 of her cycle. And day 4 of her cycle, it's not possible to be pregnant if you're on day 4 of your cycle, right? You can't get pregnant until after you ovulate. Now, if she had a menstrual cycle 2 weeks ago, you might want to think about it, okay? So that's why D is not the right answer. Assist the teen in choosing another method. Why would we want to do that? Is it an appropriate choice for a teenager to take Depo-Provera?
Yes.
Sure. It's long-lasting, it's incredibly effective, it's easy to use, she doesn't have to take pills, she can't forget to take it. It's not a bad option. Matter of fact, the only person I offer Depo to is teenagers, okay? Because they shouldn't be having sex anyway, and Depo is going to make them fat and bloated and make their hair fall out and make them bleed and give them acne, and so it makes them really unattractive. So it's kind of win-win, right? No, I'm teasing. But yeah, so it's an appropriate action to give that teen Depo. And then document that the education was completed. What education?
Now it's back and forth between A and C.
I mean, you know, taking Depo.
Yep. So yeah, she is a perfect candidate for Depo. Give her the shot. Okay. Also, by the way, what does progesterone do in early pregnancy if she, by the way, happened to be pregnant?
It speeds it up.
Doesn't speed it up.
No,
Like,
it
it's
helps
the
with the
pro-pregnancy
walls.
hormone, so
Exactly.
it's like the uterine, everything. great.
Yeah, progesterone's a pro-pregnancy hormone, right? We give it to women who are struggling with getting pregnant. So it certainly isn't going to hurt the pregnancy, even if she is pregnant, and we give her a shot of Depo. All we've done is waste $15 for a shot. Who cares? I got $15, right? Not for you. All right, so that was 41. A lot of you missed 43 and 44. Do you want to talk about them?
Well, honestly, 43, I was like,
I
I
just
remember
didn't know
talking
the
about
answer,
Ashburn
that's
syndrome,
all.
but I didn't remember like what it was. So.
Sure. I accepted A and D
Oh.
because both of them are correct, okay?
I didn't pick any of those.
Asherman syndrome, you only get Asherman syndrome after an abortion, after an elective AB, but you also, it is a uterine abnormality, okay? It's not the uterine abnormality like a bicornuate uterus or a fibroid or something like that. It's an iatrogenic uterine abnormality, but it is a uterine abnormality nonetheless. So both of those would be okay, but in this one, definitely A is what we were looking for specifically. 44, any question about why the answer is Clomid? Who knows what Leukeran is?
That's the cancer.
I didn't know that.
It's a leukemia drug. And estrase? Menopause. So there's your two obviously not the right answers. How about follicle-stimulating hormone? Why is that not the right answer? Definitely follicle-stimulating hormone is what makes someone ovulate, right? But if you looked on your book and you talked about a woman who was having difficulty ovulating, there's 3 paragraphs on why Clomid is an excellent choice. And there is a mention of the idea of gonadotropins in your book, but it is just, by the way, some people use these weird things called gonadotropins. FSH is not the first-line drug. It's very difficult to use. It's IM only. Nobody would jump to FSH. It just doesn't make any. It's just not practical. Give someone a shot of FSH every day. No, give the easy stuff first, which is Clomid. Okay, so that's why FSH is not right. By the way, we very rarely give hormones directly, like FSH or LH or that kind of thing. It's almost always a medicine that makes the hormone come, like Clomid. Okay?
But also,
Go ahead.
correct me if I'm wrong, so like, follicle stimulating hormone happens first, and then that tells the luteinizing hormone to release the egg, right?
No, follicle-stimulating hormone and luteinizing hormone go at the same
At the same
time.
time?
And they have two different actions.
Oh, well, I got the right answer, but I rationalized through it, because I was like, well, I thought it'd be a problem with the luteinizing hormone, because I
No,
thought that.
the luteinizing hormone supports the corpus luteum.
Well,
Follicle-stimulating hormone supports the follicle. 46, 10 of you got that right.
okay.
And here we are, she's a woman taking progesterone, and progesterone slows everything down. And what does progesterone do in pregnancy but cause swollen ankles? Because it causes vascular relaxation.
But it stops staying bad.
So reassuring her that this is a common side effect is the right answer. This was a tough one. I gave some alternative answers because I gave you 2 sources and the 2 sources disagreed. Okay? The correct answer is the most effective contraception on that list is Depo-Provera. 99% effective, no user error in Depo-Provera. It is the most effective on that list. Okay? So that's why the answer to 47 is B. Okay? Because that's number 1. 48, the second choice, is E, oral contraceptive pills. Very effective form of contraceptive, providing women are using it appropriately. 95% effective, or 9 out of 100 women will get pregnant using oral contraceptive pills. Condoms and diaphragms are where the disagreement comes. Those are number 3 and 4, but either one is fine. If you put condoms first and diaphragms second, that's okay. If you put diaphragms first and condoms second, that's okay too. Because your 2 sources gave a different answer, okay? Your book says that condoms are 85% effective, diaphragms are 84% effective. But if you remember that CDC handout I gave you, looking at them, the CDC handout said that 18 to 21 people who use condoms will get pregnant, or 18 to 21 out of 100, and diaphragms it was 12 out of 100. So the CDC has them swapped a little bit, and since I gave you both sources, I accepted both answers. But both of the barrier devices are better than natural family planning and withdrawal methods, okay? Now, natural family planning and withdrawal, 5 and 6, are again swapped depending on who you ask. So I accepted either way. But 47 and 48, hands down, no ifs, ands, or buts about it, that's the order. 49 and 50, I accept A or C. And then 51 and 52, I'll accept E, or what, I'll accept, where is it? F and D or F. And of course 52, I accepted anything. Okay? Because there was no space for F. 55 has got a lot of people. Read the question. Why did it confuse people?
Which one?
55.
Oh, I don't know, I actually got that right.
Okay. So this is always confusing to me. An X-linked dominant disease. Okay? Do men pass X's off to their
No,
children?
they pass the Y to the.
That's right. They pass the Y to the males, right? They pass the X to the girls, right? So if the father has it, because it's in the father's family, he's not giving any X's to his sons, right?
Right.
So none of his sons can get the disorder because it's on the father's side of the family. Okay? Now, if it were on the mother's side of the family, then yeah, half of the girls or half of the sons could have it, right? But none of the sons can get it because it's on the father's side of the family. Make sense? Good. Don't ask me to describe it further because every time I say it, it works for 30 seconds and then it's gone again.
Excuse me.
'57 through '60, you guys did well.
Yeah.
61 and 63, not so well.
63.
Oh, you're.
I'm
it's
sorry,
on the next
61
page.
then. Well, 63 is the next page.
Okay.
So, 61. The nurse discussing fetal development describes the hormone responsible for suppressing the maternal immunologic response. What suppresses everything?
Progesterone.
Ding, ding, ding. A lot of you people put human chorionic gonadotropin, and I not really able to understand why.
What's
What's that?
You're pregnant.
Because it tells you you're pregnant. It doesn't suppress anything. Human chorionic gonadotropin stimulates the production of progesterone, but it doesn't suppress the immunologic response. It causes progesterone to do it. Human chorionic gonadotropin is the manager. Progesterone is the worker who actually does it.
Oh, the folic acid.
Ah, 63 was the folic acid question. So, a woman is starting on birth control, tells the nurse she wants to become pregnant next year. What action by the nurse is most appropriate? Okay? So our assessment is we have a woman starting birth control who doesn't want to get pregnant now, who wants to get pregnant next year. Okay? That's our assessment. Okay? So what action by the nurse is most important? Okay? What are you going to do for this woman? So are you going to ask her to describe how her life will be different next year? It's kind of a little judgmental, right? Why would you bother getting pregnant next year? Why not this year? No one said that was a good answer. So, yeah.
Can you say stuff like that when we take our test? Because that makes it obvious.
No, you just have to assume that I'm thinking it. Educate the woman about the need for folic acid supplementation before conceiving. I think I jumped up and down about that one, didn't I? About how important folic acid is for all women of childbearing age, regardless of their plans to get pregnant. About how 50% of pregnancies are unplanned. About how birth control methods fail. About how every single person in this room who is not in menopause should be taking some form of folic acid.
I thought you said that after the test, though.
Did I?
I don't know, that's when I remembered
That's,
it.
that's too bad because that was a good answer.
That's when I remembered it, I remembered it after.
Have the woman make a pre-pregnancy appointment for next year. A few of you type A people are planning 12 months in advance. The average woman starting contraception is planning 30 days in advance, maybe a week or two. But, the only time you ever plan a year in advance is when you got to plan those stupid dental cleaning things. And even I can't even do that
I
either.
say they plan it.
Yeah.
Right? That's what I call it, schedule.
Remember, in pregnancy, we plan week by week. We don't plan a year from now. Okay? And tell the woman that it's difficult to get pregnant right after birth control. It is not.
Isn't there one that takes
Not
like
that
10
one.
months or
Yeah,
something?
Depo.
Okay.
That's the only one.
But that's what was in my head.
Yeah.
It's like, like she needs 10 months.
So there's one method out of 3,000 that are going to affect us. So I'm going to make a big deal about that one method. Probably not the best idea.
Oh, but it could have been right.
It could have been right, except it was wrong. Okay. 67 and 68, you guys struggled with that one too? During preconception counseling, the nurse explains the baby is most vulnerable to the effects of teratogens during organogenesis, right? During which period? So when does organogenesis happen? During the embryonic phase. And when is the embryonic phase? 2 to 8 weeks. Okay? I agree. 4, 5, and 6 is within 2 to 8. But 10, 12, and 15 is not. Okay? So you just had to know that organogenesis, teratogens affect the organs during the embryonic period, and the embryonic period is 2 to 8 weeks.
They giggled.
That is the only time it matters. Yeah.
After, again, it was
How many
after.
times did I say crack cocaine? I actually watched the lecture today, and I said crack cocaine was bad for you because it caused abruption, and it caused
I thought I remember that also after the test. when you
I said it like
talked
6
about
times.
That's what I'm saying, when I remembered
I
it,
know.
it was like after the fact. I was like,
Yeah.
oh man, now I know.
But
Maybe that in my
yeah,
head.
I was like, cocaine is bad for you, and I was like, hee.
Don't do cocaine.
You try to warn him. You guys did pretty well from 69 to 73.
Well, I didn't.
That was 68.
I can't go back any further, okay. Any questions from 69 to 73? Okay, let's get to 74 then. Did you read about Tay-Sachs?
I remember that from health assessment or, some other class. I think it's because it sounded
That was
Jewish.
just in my brain.
In my brain.
Somewhere, I don't know.
Me too.
I understand. From a community health perspective, African Americans have a raw end of the deal. But not this time. This time it's those dang Jews. No, I'm kidding. It's the Jewish baby. That's the problem. It's Ashkenazi Jews.
You
Okay?
said something about, I don't remember reading that or knowing about it or
Okay.
anything, but I just remember one day in class you said something about something Jewish and I just felt like it would apply.
Well, there you go.
And
That'll
I
work.
lucked out.
Right.
Now, by the way, which disease, which condition needs to be screened for if you were going to say African American? Which is the sickle cell, right? Good.
I would've got that.
There you go. And how about here's a good one. Who gets thalassemia major and thalassemia minor? Alpha it's Mediterraneans. Mediterraneans get a thalassemia, alpha thalassemia, and Asians get beta thalassemia. Either way, it's not the Jewish.
That's one of those questions.
That's one of those basic knowledge questions that I promise you'll see again. That's one of those stupid things they will ask on the NCLEX. The NCLEX is almost all based on like safety and that sort of stuff. Yeah, that's like painful and painless bleeding. They're the things that people just love to ask that question. You see those all the time. 76, we didn't do so hot on 76. 76 said a patient was 28 weeks pregnant, calls the obstetrical clinic and complains about irregular, painless contractions that last for 10 to 15 seconds. What response by the nurse is best? So, I understand, I have a kind of laissez-faire attitude, okay? But you always have to think safety. So let's go back to our assessment. What do we know about this patient? ADPI, assess. What is it? Pregnant. Woman, 28 weeks, okay? So what do we automatically know about pregnant women at 28 weeks?
They start getting the breast.
They certainly could be having Braxton Hicks. What else do we know about pregnant women at 28 weeks?
They should not be delivering a baby.
They should not be delivering a baby, exactly. So you have two major conflicting problems here, right? This could be normal, this could not be normal. I don't know. All I know is that at the moment, she's having contractions that last for 10 to 15 seconds. And they are irregular and they're painless, okay? So they sound an awful lot like Braxton Hicks contractions, right? They certainly could be. Or they could be early contractions, okay? They could be the very beginning of labor and we're not exactly sure. So if they last more than 60 seconds or become irregular or become regular, call back or come in. That certainly is a safe thing to say, right? You certainly don't want to be the nurse that the woman comes in, delivers a 28-weeker and says, I called and Miss Wilder told me they were just Braxton Hicks and I didn't need to worry about them. Who wants to be that nurse? No, I don't.
Yeah.
So we always talk about if you're having contractions, more than 6 contractions in an hour, or they're becoming regular, or they're becoming more impressive, then you need to let me know about it. Okay, you need to drink water, rest an hour, call back in an hour, that kind of thing. Okay, with all contractions, we say that. Okay, so, and you never want to say, oh, you're just having what are called Braxton Hicks. If you ever say, oh, you're just something, that's probably not the right answer to anything. Okay? Oh, you're just a woman. How does that sound? Does that sound dismissive?
Yeah.
Do you ever dismiss a patient's concerns? No. You always have to give them some form of validity and assess, what's actually going on. You could reassure her, but not by dismissing her, right?
Could you say, you're probably having what's called Braxton Hicks contractions, but if they last, like in real life?
There you go, as long as that but is there.
If
Yep.
they
They
last
sound an
longer,
awful lot like Braxton Hicks, but if this or this happens, you're going to let me know about it, right? That's where that comes in.
What was 80?
Oh, yeah. Did we have this test after the postpartum hemorrhage?
Yes.
Okay.
No,
So-
before.
No, before,
Yeah,
Did we?
day before.
So what do we know about the physiologic adaptations to pregnancy? What doubles, or what goes up 40 to 50%? Her blood plasma volume, right? Then why does her plasma volume go up? To protect her against heavy bleeding, right? So she's not going to respond to heavy bleeding very well. And this happens all the time in the emergency room, by the way. All the time. Is they got a woman who's had some kind of trauma, and 6 hours later they send her to labor and delivery. And we're like, whoa, 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 what were you thinking? Okay? They're going to die before 6 hours. If they're going to abrupt, it's going to happen immediately. Okay, so we always want to get your pregnant women to labor and delivery just as soon as you know that they've cleared the C-spine and you've got a splint on it or something, and get her up to labor and delivery fast, because something bad can happen really easy. So the blood loss from the laceration has not been that great. No, she's pale and diaphoretic, right? And she's bleeding heavily from a laceration on her thigh. Bleeding heavily from a laceration on her thigh, that sounds like a lot of blood loss, right? So it's not that great. It's not that one. She's in shock from the trauma and the injury, from the trauma of the injury and the blood loss. Well, could be. Okay. Her increased blood volume is maintaining her blood pressure. That is exactly what's happening. Okay. Now, even a woman whose blood pressure is being maintained during bleeding will have her pulse rise, will become a little tacky and pale, that kind of stuff. But the important thing here is that her increased blood volume is protecting her. Okay? And, I mean, her vital signs and physical assessment don't match. That's duh. That's true, right? There's definitely something wrong there. But the answer is that her blood volume. A lot of people struggled with question number 82. What is taulism?
It's excessive spit.
Excessive spit, right. And by the way, it's not called pitilism. It's called taulism. A heavy T, pretend you're saying a P, but don't actually say it. Taulism. That's how you pronounce it. It's not pitilism, but everyone calls it pitilism. But it's taulism. Okay? So, if you've got taulism and your mouth is filling with spit all the time, certainly swallowing the spit is what you want to do. What happens if you tell a pregnant woman to eat all the time? She'll gain a Backstreet Boy. Okay? Not a great option, right? So the best option is to give her something to chew on that's not going to make her fat. So lozenges and chewing gum. And let's see here. Who do you give small frequent meals to? People with heartburn? All right. 86? Well, 85 you guys struggled with, and 86 you struggled with. On 85 I accepted A or B, but not D. So let's go back to this. What is the assessment on 85? What do you know?
Pregnant,
Pregnant?
sharp right-sided lobe pain.
Okay. So, in your so you've got your assessment. She's pregnant, having sharp right-sided lower abdominal pain. Does that tell you anything?
Where it just describes it.
Tells you something's wrong.
Yeah.
So you got to know more, right? So now we know this is an assessment question because we still haven't figured out the question yet, right? So we need to ask her some more questions. We need to assess her more because we haven't got an answer. Okay? So do you have fever, constipation, or diarrhea? It's not a bad choice, right? What could be causing right-sided lower abdominal pain? Appendicitis, right? So we want to kind of rule that out if we can, right? Have you fallen down or experienced any other kind of injury in the last few days? What do you think they're looking for?
Internal bleeding.
Placental eruption, right? Happens from trauma.
Sorry.
Okay, that would cause pain. Okay, it would. So either of those are pretty decent questions. But if she had fallen down, the pain wouldn't be right-sided lower abdominal pain. It would be intense contractions all over the place. That's why B is not the right answer. But I accepted it because they're both assessment questions. You're both getting there. You're getting there. Okay, either one is valid. Have you tried placing either heating pad on your, or ice pack on your abdomen? Is that an assessment? No, that's an intervention, right? You don't even know what's wrong with her yet. You've already assumed you know, and you've told her to use ice. Okay? And is the pain worse between your navel and hip bone or closer to the hip? Now, I was confused as to why that was such a popular question, a popular answer.
I thought you wanted to locate specifically where it was. I thought it was like a secondary question.
Okay.
You have right-sided abdominal pain. Okay, where exactly is it, kind of thing, is what I was thinking.
Okay. By the way, what is that question referring to? What are they trying to rule out with that question? Who said it? Appendicitis. Okay, that's McBurney's point. That's where you push to get rebound tenderness for appendicitis. But here's the problem. Is her appendix there anymore? No, she's pregnant. Her appendix is up here somewhere. So she's not going to have pain down here if she's having an appendix. It's one of those confusing application questions. You're like, damn it. It's not basic knowledge anymore. I now have to take my basic knowledge and apply it to what could possibly be wrong. Right?
Let's not do that.
Yeah. Sorry, you're seniors now. I'm only allowed to ask, 10% or less basic knowledge questions. 80% have to be of application or more. Application or analysis. Yep. Now, let's see here. 86, according to Ruben. How many of you read about Ruben?
I read enough to answer that. I was between A and D, and I changed my answer. I'm kicking myself.
Only one of those four things is Ruben. And that's A. The other three are Smith and Watson, I believe it is. Not Ruben.
Yeah.
And, you know, by far the most important thing for a pregnant woman to do from the Ruben perspective is accept that she's pregnant. And what's that old cadence? Oh, your Liza Jane. Right?
We didn't do that, Kaden.
You didn't do that one? Oh, I love that cadence.
Oh, that's
Dress it right and cover down your Liza Jane.
We don't sing cadence.
No, because you're the Navy.
Y'all do PT?
No, it's hard to drive a boat to cadence. In the Army, it's all about walking, right?
Yeah.
Louie and Ricky, they get us everywhere we want to
You still run
go.
the boats, don't you?
Do I?
You still PT on the boats, don't you?
I was like, go ahead and make her lie.
Okay, 87. Woman in her first trimester, first pregnancy, confides to the nurse that she's not really sure that she's happy because so many things in her life will change. She's not sure she's willing to alter her current lifestyle. What action is most appropriate? So, assessment is, she is first pregnancy, first trimester. Yeah, everything is wow. Right? The whole world is changing. So she's not happy. She's not sure she's happy. She's not sure she's willing to alter her current lifestyle. What action by the nurse is most appropriate? So, A, Ask her if she'd like to see a counselor.
It's like dumping almost.
It is kind of dumping. It's also failing to recognizing what? What is really important about that response to the first trimester of the first pregnancy?
Like something, like it's not okay for her to feel that way.
No? The opposite.
It is.
It's okay.
No,
Everyone feels that way.
Right.
Oh, I know,
Okay.
but I said
That's
if
what
you
she
Right.
was saying.
Oh, okay, yeah. That's what's really important is that a lot of women, almost all women, first trimester, first pregnancy, are kind of overwhelmed and ambivalent and wow, this is shocking, okay? So that's a normal response to the first trimester of the first pregnancy, okay? So you don't want to refer someone to a counselor or to a support group because they're normal, right? Then you don't refer people who are normal. You have to explain to them that they are normal, okay? So reassuring that ambivalence is normal now, yeah. Tell the woman she needs to think about her unborn child, no, that doesn't help. And luckily, none of you chose that one. But reassuring that she's normal is the right answer on that one, okay? And on that one, you had to know what was normal and then apply it to your patient. Because you're gonna see it if you talk to pregnant women, okay? And you wanna make sure that you give them appropriate information. You guys did okay with 88, 89, and 90. 91, we struggled with. I accepted C or D, which leaves 4 of you out, I'm sorry. A woman in her first trimester is upset and worried about the physical changes of labor and birth process. Being able to care for her newborn, which action from the nurse is best? Asking about exposure to newborns? Well, it's not a bad question, right? How many babies have you been around? But does that solve her problem? Does that help solve her problem?
No.
No, not really. Assess the woman for access to a knowledgeable support person. Again, not a bad question. Do you have a mom or someone who's around who can help you? Okay, but that doesn't really solve her problem. It's not bad, but it's not great. Provide information about childbirth preparation classes. That's going to help her understand the physical changes, right? That might actually help. And reassure the woman that her fears are natural. That's a pretty good answer too. Okay? 91, we struggled with. Oh, we just read that one, right? 92, we did good. 94, 95. Everyone good on 92?
Yes.
Okay. I was happy to see that most of you got the Leopold's questions right.
Wait,
Down.
92 was a Leopold's question.
Yeah.
93, we did okay on. 94 and 95, not so much. But that's okay. I accepted A, B, and C for 94, which means only 3 of you missed that one. And 95, I accepted any answer, so all of you got that one. So let's see here. 94, the nurse believes in advocating for the patient. What action by the nurse best reflects this role? So the correct answer is helping her formulate and vocalize questions. Documenting her preferences are okay, but that doesn't really advocate. Informing the woman about what options are related to childbirth, that's pretty good too, that's why I accepted it. Teaching her about the physical changes that occur during pregnancy, not so much. Because while that definitely prepares her, that's not advocating for the patient.
See, I got the wrong ones right.
That's what worst.
Yeah.
95, I threw that one out because I hated the way it was worded. I would have chosen a different answer. The answer is that yes, pregnancy is a developmental crisis, but I hate to think of pregnancy as a developmental crisis. In a clinical, psychological term, it is, but that's an ugly way of wording that.
Well, you said it though. Everything is changing.
Exactly. The whole world is changing. It's not a good idea to say it's just hormones. That's insulting to say it's hormones, right? That's really not okay. But it is the hormones that are making a change.
Right.
Okay? It's just not okay to say that. Many are afraid of labor and birth. Doesn't really solve the problem. You have to finish it up with something. Okay? And most pregnant women don't feel too well. That's not true. None of you answered that anyway. 96. I like 96 because let's teach you a little bit about therapeutic communication. So, well, 19 of you got this one right. So you got your good idea about therapeutic communication. But Therapeutic communication, you always want to think, what is an open-ended question that the answer could not possibly be yes or no? Okay? So whenever you see therapeutic communication and you see a closed-ended answer that could be yes or no, that is probably not the right answer, right? And that's why D is the right answer. To begin with, what questions do you have that I can take care of? Where do we go from here, right? Totally wide open, you can do anything you want. 98, I accepted. I know I
Or
did.
D.
Did I forget to write it down?
No, it's on your sheet.
No, it's right there next to it.
Okay, C or D. Ah. Hagar sign. What is a Hagar sign?
That's the,
Isn't it the cervix?
Turning
The,
blue.
That's Chadwick's.
That's what I was thinking.
It's the thinning.
Softening.
Softening.
Yeah, it's the softening of the cervix or softening of the isthmus of the uterus. Chagar, Hadwick's, and Goodell's are the three signs that are presumptive for pregnancy. It doesn't mean they are pregnant. It means they're probably pregnant. But both of them are correct.
I thought Goodall's or whatever was the softening. Like I got it right, but I thought
I always get the three of them mixed up. It's that
Hagar's is something different, but I know
Yeah.
it's an indicator of pregnancy.
Chadwick sign I can always remember. It's the bluing. But Hagar's and Goodell's sign, it's the softening or thinning of either the isthmus or the cervix, and it's really nitpicking. It doesn't matter.
The only reason I chose May is because I just remember you in lab being like,
Yeah.
well, yeah, but just now we just test it.
Exactly. The only way that we know somebody is pregnant, there are only two things that absolutely say someone is pregnant. What's that?
Fetal movement and heart rate.
Exactly. Fetal movement and listening to the baby's heart rate. That is the only way you absolutely know that they're pregnant. Okay? But that's why, so C is, well, C, this is probably more accurate, but I accepted both answers. Because you're not going to get Goodell's sign or Hagar's sign if you're not pregnant. Okay? It's just no one ever uses it. No one would ever do a pelvic exam and go, ooh, that's awful soft. Oh, you must be pregnant. No one would ever do that. So it's a little bit ridiculous for that one. Okay? 99 and 100, you guys did well on that one. 99, 34, 15 of you got the right answer, and 113 of you got the right answer.
All right.
No one should have missed 99. I think that was, what does para 3 mean? It means she's had 3 deliveries after 20 weeks, right? Okay, and 100, is it okay to take flu shots in pregnancy? The answer is yes. Take your flu shot in
They
pregnancy.
always offer them to you.
Yep. Now, a lot of people struggled with the way this question was answered. Some of you couldn't quite figure it out, but you drew great diagrams that showed me the answer, and that was perfectly okay. Okay. Because I recognize this is a little challenging. And I recognize that the book talks about going up into the head and back down, and that's really kind of superfluous and it doesn't matter.
Can I ask
So,
a question?
yeah.
I thought, well, obviously I'm wrong, because I got ductus venosus and superior vena cava flipped. I thought I had to go through the ductus venosus to get to the superior vena cava.
The superior vena cava is coming in from the top. The
Okay,
inferior
oh,
vena
inferior.
cava, I switched it, yeah. So yeah, you got, as long as you put ductus venosus or inferior vena cava as 1 or 2,
Oh, okay.
then you got it right.
Oh, okay, that's what I was
Okay,
thinking.
that's
Yeah.
because I have ductus venosus
Yeah.
as 1 and then
Yeah.
inferior vena cava.
I accepted 1 and 2 interchangeably, okay? Because technically, it is ductus venosus into the inferior vena cava. But because it comes from the umbilical vein. But if I wanted to be that tricky, I'd have had to start with umbilical vein. And it would have been umbilical vein to ductus venosus to inferior vena cava to right atrium, through the foramen ovale to left atrium, up into the down into the left ventricle, through the aorta, into the through the pulmonary artery and the aorta, and then to the aorta by way of the ductus arteriosus. So I accepted that the aorta, the ductus arteriosus, could get swapped, and the inferior vena cava and the ductus venosus could get swapped. Okay? And I recognize that not having the left atrium confused people. I recognize that. Okay? But, so that is the right answer. And the trick is that you go through the ductus venosus, you go from the right atrium to the left atrium through the foramen ovale, and that your blood gets through the rest of the body to the aorta through the ductus arteriosus. Those are the important things about that. The next are B, D, and C. Simple Nagel's rule. A lot of you missed number 9 because you took your 3 months away before you added your 7 days. Okay? You have to add 7 days. That moves you to August 3rd. Then you subtract 3 months from August 3rd and you get May. If you took 3 months away from July, you got April. And you said April 3rd.
You should have had that all over the test.
They're bonus questions, they're gimmies. Okay? And on the pregnancy, I thought it was interesting how many people got this right, but called the 18-week loss a fetal demise instead of an abortion earlier in the test. Yes, ma'am?
I got that wrong.
Kind of an adjunct to this question. I was at the STD clinic on Thursday,
Uh-huh.
and I got to follow the provider around. And it's not a nurse, it's not like an assistant, like it's a provider, like they need to know their stuff. So we go in there, and of course it's all sexually related questions, history, assessment, stuff like that. And she gets to the pregnancy screen, and the GTPL was on there. I was like, oh cool, we just learned about it, I know what that stands for. And she asked her, she was like, how many you had, how many per living, did you have them at term, blah, blah, blah. And the lady said, no, I had an abortion, and she put a 1 in the L column. And I was like, shouldn't that go in the A? And she was like, oh no, the L stands for living.
Right, you
Or
had
loss, no, the L
Oh.
stands for loss.
L stands for loss.
And I was like, no, it doesn't.
Yeah.
And she said, oh, okay, and I felt bad because I was like, crap, the patient's right here, that made me
Yeah.
look like an ass, but it was exciting because I was like, you're wrong. And it made me think, I was like, well, crap, if this is just one that I'm with her with, how many charts are messed up in this system?
I think you did the right thing at the wrong time.
Yeah, I did, and I didn't realize
Yeah.
that until I left. I was like, crap, she's probably.
Yeah, it never goes well to embarrass a provider or embarrass anyone in front of the patient, right? That just never works for you. All right, let's take a short break and come back.
You know, I don't see, because of this,
Oh, there it is.
the slide sheet that you
I was supposed to say, I texted you, did you do it right?
on Blackboard, right?
Weekly under section 4? Or under week 4? Oh yeah, I'd like your test back, please.
It should be, well, so far on week 4.
I can't feel my face.
What?
But I love it.
That's
There's something wrong
paper
with
in the
y'all.
pocket.
Yeah, I know.
My cousin, she wanted to tell me that.
I know what